It's fantastic to have you all join us on Zoom for this final of the masterclass webinar series, looking at the opportunities that there is for OPAT or HITH, so and antibiotic use in that scenario. We've had 3 very good webinars earlier on in the year. This represents this current webinar of treating infections in cancer patients is the 4th, and we really enjoyed the topics of respiratory infections, bone and joint infections, and infective endocarditis. And it's really been a pleasure for CRE Reduce, which is the Centre of Research Excellence, which I'm fortunate enough to be director of, to support and drive a lot of this. So my name's Jason Roberts. I'm based at the University of Queensland, the Royal Brisbane Women's Hospital, and you're not going to hear much at all from me tonight because our chair is Dr. James Pollard from Cabrini Health, and I'll invite him to take over in a moment. And we have 4 excellent speakers for today. I did want to say just a couple of words about how successful this webinar series has been, and I think that I'm really happy that it has been able to be that level of success given what a challenging year 2020 has been. So I estimate that there's been over 1,000 participants that have registered for these webinars, which I think is fantastic. There's 16 lectures which will have been given by the end of the webinar series, and they'll all be included on our freely available YouTube channel, which you can find through the CRE Reduce website. And most importantly, I think there's just been some fantastic discussions and increasing awareness about the usefulness of OPAT/HITH concepts and applications for healthcare in Australia and beyond. This wouldn't have been possible without our sponsors, and I'm very grateful to MSD, Pfizer, and Baxter for their support of these webinars, and also for the support from James, as well as Ben Rogers, and the ideas that they've generated over the course of the last 18 months or so as we've tried to bring this forward. So I'll conclude there, let James take over, and then you can enjoy the wonderful views of our speakers. Thanks, everyone.
Thanks, Jason, and welcome to all our attendees who I can see are coming on board there now. Thanks firstly to Jason, to Luminator, and to CRE Reduce. It really has been a great series, and we're looking forward to a really excellent series of presentations tonight as well. For our attendees, a reminder, we have the Q&A toggle there, so add your questions into there and we will filter them and try and get them to our speakers either at the end of their initial topic or towards the end if there are unifying topics as well. We are very lucky to have 4 excellent speakers tonight, and I'm going to introduce Dr. Gabrielle Haeusler first. Gabrielle is from the Peter MacCallum Cancer Centre in the Royal Children's Hospital here in Melbourne. Associate Professor Gabrielle Haeusler is an infectious diseases physician and a clinical scientist with an expertise in infections in cancer patients. She has clinical appointments at Peter Mac, the Royal Children's Hospital, and the Paediatric Integrated Cancer Service in Melbourne. Gabrielle's research program seeks to optimise management of infections in cancer in children through enhanced surveillance of fungal infections, implementation of evidence-based care pathways, and evaluation of novel diagnostics. And it's quite fitting that she opens tonight telling us about treating infections in cancer patients. Thanks, Gabrielle.
Unmute myself. Thank you very much for the opportunity to present on this topic to CRE Reduce. This topic is particularly close to my heart. I've done lots of work in this space in both adults and paediatrics, so looking forward to sharing some of that with you.
Just lost you on mute there, Gabrielle. There you go.
Sorry. So for the next 20 minutes, I just want to give a bit of background on home-based febrile neutropenia care, and particularly some evidence for that, and talk about the experience that we've had at some hospitals in Melbourne with probably with more of a focus on our paediatric experience and what we're doing with scaling the program nationally. So I'm sure many of you will be aware that fever and neutropenia is one of the most common cause of ED presentation and unplanned hospital admission in adult and paediatric cancer patients. And we've identified an infection or serious medical complication in about half of all patients, particularly in the paediatric group. Sometimes that varies in adult patients depending on what the underlying diagnosis is. But across both adults and children, home-based management of low-risk febrile neutropenia in a very structured program has shown to be safe, improve quality of life, reduce length of stay, and reduce healthcare expenditure. And this is a lovely systematic review produced by Jess Morgan and Bob Phillips out of the UK, looking specifically at the data for paediatric low-risk programs. And they pulled all the data and showed that outpatient treatment failure compared to inpatient treatment failure, there was no significant difference there. But children were more likely to fail going home early for home-based antibiotic management of their febrile neutropenia if the clinicians didn't use a structured clinical decision rule or care pathway to decide which patients should go home or not. And similarly, that there was no difference between oral or IV with regards to treatment failure. So based on the mounting evidence of the safety and improvements in cost and quality of life for home-based care, it has been recommended in a number of national and international guidelines. So these are the guidelines from Australia. They're a little bit old now, in 2011, but really the recommendations don't change for risk stratification and early discharge of low-risk patients. In paediatrics, we've produced a more recent guideline that again recommends centres adopt a risk stratification strategy and implement that into management. And this paper of an ASCO guideline update published in 2018, again similarly recommending that adult patients risk stratified according to a MAS score or the Talcott score and discharged home. However, implementation with these things is always the key, and you can put all these recommendations into a guideline, but how that translates into practice is a different story. And so when we think about implementing new programs of care, I like to think about use that consolidated framework of implementation and really think about all the different areas that you need to consider and look at before implementing something new. And so it's that intervention itself and what are the benefits and risks of that with the actual implementation process. So how are you going to introduce it? So a new change of practice to clinicians, what's going to be the process of evaluation and feedback. It's really essential to get the key stakeholders involved early and part of that co-design of this new program. And with regard to low risk home-based management, that's obviously oncology, hematologists, infectious diseases, and the hospital and the home programs, as well as pharmacy and the emergency department, and of course patients themselves. And then thinking about that inner setting, what's going on within the hospital, is there executive level support, and then right down to the individual and thinking about, these programs, ultimately it's the oncologists and the hematologists that are responsible for their patients coming in. So really they're the key people that need to be involved in the design of this to make sure that it's not really set up to fail from the beginning. And really we need to remember that at the centre of all this is really the patient themselves and really doing what's best for the patient. So thinking about that, going back to that a step slightly and thinking about that clinician confidence in programs. So this is a results of an adult survey of practice and a paediatric survey of practice, and really surveying oncologists, hematologists, infectious disease physicians, all those key stakeholders that I mentioned earlier about their confidence in home-based management. And what was really striking across these both surveys in adults and peds was that right up the top as being, identified as one of the most important factor was really that hospital capacity to follow up patients, and that patients were entered into a structured program. And interestingly, across both groups, the cost to the hospital really rated much more lowly down on the relative importance to the clinician that is going to be ultimately making the decision to send these patients home. So when we think about the febrile febrile neutropenia journey, and this is the same across both adults and children, that, you know, the management is really very similar. There's that early recognition and initial management pathways, early antibiotics if patients have sepsis, making sure there's the appropriate use of diagnostics and blood cultures taken at the right time and the correct volume, etc. And then after that, and you've got a little bit of clinical information and results of a full blood count, you can do that risk stratification process. So which is really, that concept is differentiating patients into low or higher risk of an infection. And when we use a validated clinical rule in paediatrics, about 40% of children will ultimately be deemed to be low risk. So in adults, as I mentioned, that those two rules, the MASC and the Talcott rules, are most widely used and recommended rules. But the story is quite different in children. There's up to 20 different clinical decision rules that have been developed around the world. And as part of a national prospective multi-site febrile neutropenia study in children that we finished a year or two ago, we were able to validate a number of those clinical decision rules. And based on that, we did some recalibration and looked more at what was more relevant for children across Australia. We came up with our sort of recalibrated version of a Swiss rule based on some Australian, UK and Swiss data. Therefore, it's become the Oz rule, and that's what we're recommending for use in Australia. So the Oz rule is a bit different to just simply stratifying into low and high risk. And so it's relying on 3 clinical variables that are readily available to patients when they arrive in the emergency department. So it needs a white cell count, a platelet count, and whether or not they're proceeding chemo with more intensive than ALL in maintenance. And you can score a 1 for each of those. So rather than just simply giving a low and a high risk score, the work we've done which I'll show you in a moment, is really we've given some recommendations based on the score. How long is your minimum in-hospital observation period before going home? And so you can see that that ranges from anywhere between 4 hours out to 48 hours, depending on the score. But perhaps, well, equally, I think as important is that risk stratification process is really working in some safety net criteria. So that these rules are not perfect. They will identify patients that clearly that are more unwell and end up having an infection as low risk, and vice versa. So in order to kind of catch those ones that might slip through the crack of your clinical decision rule, there are some becoming more standardized recommendations about not sending these types of patients home, and these are often based on kind of consensus expert opinion, but we've adapted, these are the pediatric ones, and we've adapted those from that adult recommendations used at Peter MacCallum. So it's really just not sending home those patients with very active disease that have relapsed or in that induction phase, so getting them more intensive chemotherapy where we know the rates of infections and adverse outcomes are much higher. So going back to that Oz rule, you can see there that depending on the score, whether you're a 0, 1, 2 and 3, you can see that gradient upwards of the rates of bacteremia from 3, just under 4%, up to nearly 25% if you scored a 3. And hence that's really informing why we would recommend that someone waits at least 48 hours before sending a kid home that scored a 3. When we add in that extra layer of that safety net or hospital in the home or home-based eligibility criteria, we do sort of knock out a few extra patients that shouldn't go home. But even then, you can see the numbers that would be eligible for home-based care are actually really quite high overall. So some results really, there's a couple of publications that I've listed there. So Ben Tay and led by Kaz have looked at the processes of implementation using the MASC rule in adults, and there's been a significant reduction in hospital length of stay to 4 down to just over 1 day, with no adverse events in the patients that went home on the program. Similarly, in paediatrics, using the validated risk rule, we've reduced length of stay locally as well from 4 down to a median of 1.3 day with no adverse events. And this program, based on results of our national picnic study, is being scaled across 8 tertiary paediatric hospitals this year and started mid last year. But it's not just about the safety and reducing length of stays, etc. The quality of life aspects are also really important. And these are some quotes from clinicians and parents about the the potential benefits on quality of life about patients going home. But we also need to be mindful that it's not for everybody, and that there are certainly patients that don't qualify for this home-based care. And this is a concern from a parent there about, you know, what if something goes wrong, and I've seen my child be quite unwell in the past. And really that speaks to the importance of that safety net criteria, not sending those potentially sicker patients home. These are data, again, from the PICNIC study, where we used a validated tool to measure the quality of life of patients that were admitted for febrile neutropenia care. And this study was conducted before we had use of low-risk pathways. So this is that standard in-hospital management until resolution of fever and count recovery type approach across the board to all patients. And you can see that the orange line down here is the child's quality of life, their mean utility score. And it's quite sobering to see how far below the national average using that risk, using that validated tool that is. And it's certainly much lower at the point when they're right in the midst of their FEBNUT episode, and there's some improvement at day 7 and 30 days. You can see similarly for the parents that their overall quality of life is reduced, but it's probably not as impacted by the FEBNUT episode as much. It's probably that overall cancer diagnosis for their child that's impacting them there. So just to summarise those key points about transferring patients home, particularly for paediatrics, but again, I think that this is relevant across the board, that there has to be some minimum period of in-hospital observation just to make sure that there wasn't some early missed sepsis that might evolve. And that can be done in the emergency department, in that short stay environment, or if they're needing a bit longer, up on the ward for a day or so. And that before going home, those patients really need to fulfil that home-based care criteria. We recommend that they're reviewed by someone senior in the oncology team in paediatrics, whether it's a consultant or fellow, and that the patient themselves and family receives appropriate education. And we've really taken that multidisciplinary approach to the management of these patients while on the program, engaging the emergency department early in case these patients need to represent, etc. So now shifting slightly and thinking about the antibiotic options for this home-based management. And one of the unique things, and I think that this will potentially be discussed later, is that children are not little adults, and swallowing tablets and multiple tablets or a big volume of not nice tasting syrup can be quite difficult in these kids. And we initially opened our program using IV antibiotics and using that standard pip/tazo antibiotic, which is recommended for febrile neutropenia care, with the options of augmentin ciprofloxacin for children that can take that. And then we've got some recommendations that if patients have beta-lactam allergy, for ceftazidime or cefepime also being an option. This is an example of the education material that we provide to the family. So it's a list of things that they need to be aware of, but we also give them a readmission letter, and that perhaps is less relevant for patients that will only ever come back to the same paediatric hospital for all their care, and maybe more relevant for adult patients that might be disseminated more widely from the original hospital that sent them home. And it's really just to alert clinicians as to why they're coming back in. So an example of there's a contact number for the family, when to call the hospital, what type of symptoms, etc. And similarly, when the letter for the families to represent to triage and to their treating team in the emergency department if they came in more unwell, with some recommendations about what antibiotics to give if they were sick. And so the medical review criteria that's mirrored in our policy at the Children's Hospital in Melbourne really replicates that list of things that we tell the families to call the hospital about. And these would be the reason your prolonged fever or new fevers that were unexplained particularly need to be reviewed again. We've also built in discharge criteria off the program or off hospital in the home for these patients, which are very similar to what the discharge criteria would be if the patients were remaining in hospital for standard management. They've got to be well, and we've included evidence of marrow recovery. This is a controversial issue about whether if they're afebrile and well, that should be enough. And we're doing some more work, another study to look at that question in particular. But just, again, some local data from the Royal Children's in Melbourne is that the median neutrophil count at time of discharge off the program was 0.3. So really getting in under that 0.5, which is nice to see. And there were 16 episodes that were sent home, discharged and off antibiotics with neutrophils less than 0.2 and no adverse events or readmissions in that group. Monitoring and staff feedback of any program is really critical as well, just to keep on top of things, to keep making sure that you're not missing any adverse events, but really particularly to make sure that there's not eligible patients that are not getting the benefits of early discharge. We've looked at our local data again at the Royal Children's with our 18-month experience after we implemented this program. There were 292 febrile neutropenia ED presentations during that time, of which 45% were low risk. 22% of those patients overall were transferred home early, and notably 38% of those that went home had an acute leukemia such as ALL or AML. The median length of stay reduced, as I mentioned earlier in an earlier slide. We saved 291 bed days in 18 months. There was a 13% readmission rate. So these are patients that are needing to come back onto the inpatient ward during that, what would be still counted as their febrile neutropenia episode. That's consistent with international literature. There was no adverse events. Patients recovered. Predominantly, it was prolonged fever or new fever episodes. And there was 7% that were missed opportunities overall. So we looked really closely at that. Of the 88 kids that scored low risk that didn't go home, why didn't they go home? And quite rightly, most of them didn't go home because there were good reasons why they needed to stay in hospital. But there were, importantly, around 20 patients that should have gone home that didn't, and predominantly did because these patients just weren't risk assessed. And so that was kind of forgotten about. So that really close and intensive look at the program has enabled us to look at a number of different program improvements. A lot, it's been well over 18 months now that we've had this program in place. In particular, we've been fortunate to have an electronic medical record, and we've put an EMR alert in, just alerting clinicians that this patient may be suitable for the program. We've updated our clinical rule. We're looking at nurse-led discharge criteria and transitioning more patients over to oral antibiotics, and that's all undergoing review. Cost effectiveness is a really important factor to look at. So the mean cost of inpatient febrile neutropenia care for both adults and peds is $2,200 a day. And the cost is really driven largely by the length of stay in hospital rather than the particular risk group that you're in. This data is just really hot off the press, and it's come courtesy of health economist Kim Dalziel from University of Melbourne. That's looked really in more detail about the cost savings of the paediatric pre and post program, and there is actually a mean cost difference, so in favour of the program, of $20,000 per patient. So really cost effective program once it's up and running effectively. This is really quite a cool study. Again, Kim Dalziel was involved in this, but Michelle too as the lead author, looking at the cost effectiveness in adults and projecting potential cost savings across the country if every adult hospital was able to take up the program. So these is the projected febrile neutropenia admissions a year across the country in adults. And then these two graphs here, firstly look at the cost savings, and I'll highlight that these is total cost savings in millions over a 10-year period, and the total beds saved in thousands across that 10-year period. And it's really modelling lots of different scenarios about what proportion of patients might score low risk, and then what proportion of patients might fulfil that home-based care criteria. The X's you can see there are the Australian estimates overall based on some studies done led by Kaczewski at Peter Mac, but with that kind of estimation that there's up to $62 million that could be saved in over 40,000 bed days if every hospital took an adult low-risk program up. So just in the final couple of slides, thinking about what is the role of hospital in the home, or that outpatient management. And I think it really is more than just the delivery of IV antibiotics for these patients, particularly, there are patients that could be on oral antibiotics. I think it does provide that, monitoring and close observation of patients that would otherwise be in hospital, and really a key liaison point between the patient and the treating inpatient team. And I think as a result of that, and that more structured hospital in the home-based follow-up, I think that really is going to enable more patients to get out of hospital early and benefit from these early transfers home, and particularly moving into that acute leukemia group in adult patients where traditionally are excluded from a lot of the home-based care, or the early, discharge from the emergency department on oral antibiotics. And one of the barriers across Australia that we noticed when we were implementing the low-risk program, that there was a concern that there wasn't specialised oncology nursing workforce within the hospital and the home. And I personally don't think that's necessarily a barrier. Obviously, there are some important aspects of cancer care, but these patients are really at home with a potential infection being managed, and I think hospital and the home are very good at doing that. And I think by including more febrile neutropenia patients on these hospital and the home programs has the potential, though, to really contribute to a more specialised workforce development of the HITH teams. So, thinking finally about future directions, there has been an increased acceptance of home-based management of low-risk FEB-NEUT among parents and clinicians in 2020. We've just had a survey that's impressed that we were looking about the impact of COVID. I'm sorry I couldn't do a talk and get through it without mentioning COVID, on the impact that's had on our trying to implement a new model of care, and there's been some significant impacts. But really what we've noticed that there's been increased acceptance among clinicians and parents, you know, wanting to get home earlier, and there's really been this strong preference for that telehealth and outpatient appointments where that's been appropriate. I think utilising point of care tests more and, you know, early rapid diagnostics in this hospital in the home setting is really interesting. That those wearable monitoring devices as well opens the opportunity for home-based neutropenic observation rather than inpatient. And really finally, I think a lot of those, particularly the adult clinical decision rules, really need to evolve a bit more. That they were developed a long time ago, and I think cancer care has really gone ahead in leaps and bounds. We're seeing less neutropenia with immunotherapy, and I think if CAR T cell therapy can be given as an outpatient, low-risk FEB-NEUT should be really a walk in the park for these patients and the teams. Lots of people to acknowledge with all this work that I've presented tonight. There's been a number of different studies that have been funded along the way that have helped us gather this information. Thank you very much.
Thanks, Gabrielle. That's an amazingly thorough and comprehensive overview of all to do with treating infections in cancer patients at home. There's somewhat stunned silence in the Q&A, but there was one there. For the patients who are beta-lactam allergic, and I know beta-lactam allergy is fairly topical at the moment. Yeah. So for those that are allergic, do you have a screening process? Is it clinical questioning only? Do you do first dose on site? Just talk us through a beta-lactam allergy screening.
Yeah, look, fortunately, it's relatively uncommon in paediatrics and in the paediatric cancer setting. About 5 to 10% of patients are documented as having an allergy of sorts, and that there's lots of debate about how true that is. It's really there is that standard question. Most of these patients have come in and already had their pip/tazo already, so there's that testing that's been done already, but it is part of the standard questionnaire. We've not got an IV option for home for true anaphylaxis for cephalosporins and penicillin-based antibiotics, but you know, there could be options there if patients really needed to get home.
Great, thank you. Thanks, Gabrielle, for that.